he updated it subsequently with some additional discussions. He really touches on most things that are just as relevant then as they are, or now as they were then, or then as they are now. And he talks about, for example, the Portuguese Jewish congregation in Hamburg in 1666 decided in 1666 not to accept the offer by a physician to treat the poor for gratis as an act of charity because, quote, it is not fitting to engage someone without salary, for the payment will force the doctor to be in time when called in by a patient. So that there was an impetus that there should be proper reimbursement and that it shouldn't be done gratis. He talks about in Poland during the 17th and 18th centuries, physicians employed by the community or at sick visitation societies were generally required to attend the poor gratuitously and to pay regular visits to the communal hospital. But in return, they also enjoyed special privileges, including their exemption from many taxes and sometimes even the grant of a free residence. So that the community has, according to this view, a communal obligation to see to it. I don't know that that would equate to the federal government, or it would be more left to individual communities to handle, maybe at the state level, maybe not even at the state level, maybe at a smaller scale level to try to address the issues of health care from a communal perspective. And I think that that's important. I just want to close with two excerpts from Rabbi J. David Bleich's works, where he talks about this notion, and he writes in his tradition articles that he's written over the years, this must be understood as meaning that society itself is obligated to discharge the responsibility of circumcising the child, as we talked about. And similarly, although no individual member of society may be obligated to provide for the medical needs of needy patients, society itself does have such an obligation. Hence, the Beth Din, the Jewish court, and the agency administrative that is pursuant to the community may compel a medical practitioner to make his services available, or may be compelled to provide compensation to the physician to see to it that care is provided. And just one more quotation, then just one or two last remarks. Rabbi Bleich writes in a more recent article, an organized kehillah, community, would not only have the ability to arrange group coverage for its members, but it would also have halachic legal power to compel each of its members to enroll in a medical insurance plan, as we referred to earlier. There is no gainsaying that the fact that patients bereft of insurance coverage are frequently deprived of access to quality medical care, as Dr. Jacobs pointed out. Disparity in the quality of care is directly reflected in survival rates, he quotes. Although any particular individual may never experience catastrophic illness requiring treatment that is beyond his financial ability, I don't think catastrophic illness is the only category that's beyond one's means. The basic procedures, annual exams are very, very costly. Any procedure, any radiographic procedure is going to be very costly. It is a virtual certainty that some members of a community will suffer such illness. The essence of insurance, as Dr. Jacobs explained, is the spreading of losses or costs among a large pool of insured persons, so that the onerous financial burden does not fall upon a single person. In the case of health coverage, insurance also serves to provide access to life-saving care and treatment. It is that aspect of medical insurance that opens the door to enforcing enrollment of all members of the community, as he describes. So I think from a Jewish perspective, we would say that there's an absolute obligation to treat, to be treated, to be insured, and to provide insurance as an individual and as a community, and that the compensation due, whatever category of compensation is appropriate, whichever, depending on what perspective and how one defines the various categories of appropriate compensation. But it is clearly important, as Dr. Jacobs pointed out, that a hospital, which is not what these sources address. A hospital is a little bit different, as Dr. Jacobs was talking about, but that it is clearly a mandate to make sure that a hospital that provides health care be maintained, be viable, be fiscally responsible, because without that, people will not receive health care, and that becomes really a mandate the community is responsible for. In a certain sense, I'm not sure if Judaism would distinguish between private versus state or city-run hospitals, that the community has an obligation for all such facilities to the extent that those facilities are in need, that this is a communal responsibility. I think just to close, because Dr. Jacobs raised an important question regarding children, I think that it's one thing for an adult to choose not to be insured. It's another for a child who doesn't have the capacity legally and halachically, Jewish law-wise, to be able to make that decision, and therefore it becomes certainly a mandate upon the parents, and if the parents don't have the capacity to do so, then the community certainly becomes responsible for the children as well. So these are a few notions, and perhaps if Dr. Jacobs has some follow-up comments on what I've mentioned, I'd certainly welcome them.
Thank you very much for such eloquent presentations, Dr. Jacobs, Rabbi Dr. Weiss. We're going to open the floor for a few questions as we're running a little bit late. Just a few comments. The schar batala regarding getting paid for having spent the time that I could have been doing something else. I think if I have a choice, I'll rather be a money manager of hedge funds and things like that, that in 1 second you can make millions up in here and there. So I don't know if we have a chance, but being a rabbi and a doctor, I don't know to which profession to turn and ask for schar batala, because as a rabbi I cannot charge money, and as a doctor I cannot charge money, so I'm at a loss at that point. You mentioned, Rabbi Weiss, that the paragraph in the Talmud that Abaye disagreed, that he said that indeed the physician should be able to charge me, be paid for it, not just rely on healing from a Kadosh Baruch Hu. The Ramban, he writes, as you know, Nachmanides, who's a medieval Sephardic rabbi and physician also. He does prefer, and he does say that righteous people should be healed mainly by the act of God than by physicians, but since I guess most of us are not really righteous people, and so therefore we have to rely on a physician to heal us. And lastly, to Dr. Jacobs, the talk around town is that, and that was, that was from the inception of HMOs and PPOs and things like that, where that they were supposed to have been a form of slowing down or arresting the expenditure of health care, and in reality that never happened. It did happen, I'm not sure, but the talk around town was that mainly what happened was that instead of the money being divided amongst the providers, is now being divided among the high-paid executive of HMOs that have insurance. So I don't know if you could correct me on that, and I guess would you want to answer it before we open the questions to the public?
Remember, Truth in Advertising says that I have to remind you that I was on the health plan side for a number of years, so that was my last time here. Let me address the issue. In fact, healthcare cost increases flattened out in the late 90s. There was essentially no significant growth in the cost of healthcare. But I want you to reflect on what happened toward the end of the 90s, when there was this incredible, call it a revolt, against the managed care industry by patients and by physicians. Since you have three physicians standing up here, I'll say I feel badly for all of us that we really weren't the ones who forced change. It was really the patients. The physicians reared up for a very simple reason. It was economics. There was an impact on revenue, or more specifically, there was actually an impact on the way that physicians were forced to practice, and they had to, for the first time in the course of physician practice, they actually had to look for ways of increasing throughput, of doing the things that a business is forced to do. Now, by the way, I don't think having a practice that runs like a good business is bad. In fact, some of the best practices I've seen, in fact, have some of the most efficient operations, and they've eliminated a lot of the excess time and aggravation.